Well, thanks everyone for joining tonight. The lecture for tonight is one of two. Tonight is COVID, the dynamics of disease in offices and schools with Dr. Ken Zangwill. This is a two-webinar series on infection prevention and control, sponsored by the American Academy of Pediatrics through a Project First Line grant from the CDC in collaboration with the San Bernardino County Medical Society. Session one is tonight, and it will go for about an hour. Session two, make sure you save the date, is going to be on May 27th with Dr. Ishminder Kaur on SARS-CoV-2 virus dynamics, host immune response, and vaccines. To begin with the program, I would like to introduce our speaker for the evening. Dr. Ken Zangwill is professor of pediatrics at the David Geffen School of Medicine at UCLA and chief of the Division of Pediatric Infectious Diseases at Harbor-UCLA Medical Center in Los Angeles. He also is director of infection prevention and control at Harbor, where he is active on the General Pediatrics and Infectious Disease Services. He completed residency at Children's Hospital of Pittsburgh and served as an Epidemic Intelligence Service Officer at CDC, followed by ID Fellowship at Harbor. His research focuses on clinical epidemiology, clinical care, and economic analysis. Dr. Zangwill currently serves as chair of the AAP section on infectious diseases and is a member of the AAP Committee on Infectious Diseases, which is also known as a Red Book Committee. Please welcome Dr. Ken Zangwill.
Thank you, Tomas, very much. Thank you to you, and thank you to the AP chapter leadership. It's really my pleasure. Let me see if I can share my screen here and put my talk up here. Y'all can see that, I imagine?
Yes, perfectly.
Fantastic. Again, let me thank you very much for inviting me. It's an absolute pleasure for me to speak to you all. And I will also say this is a tricky topic for me to put a talk together, I got to tell you. Somehow merging infection prevention stuff and issues and practices with office practice, that's one thing. And then with schools, which is another topic, and how they may or may not intersect. So I imagine as we get into questions and discussion, I am confident I'm going to learn something. I'm talking to a group of people that live every day with dealing with COVID issues and infection prevention issues and whatnot in the office setting. So I really want to hear what you have to say as well. So, and please do interrupt. Feel free to put your camera on, feel free to yell a question out or put it in the chat. I will try to glance at the chat if I can, although I don't really have easy access to it on my screen, but I'll just get moving here. So what topics will we be discussing today? A little update on the local and US COVID epidemiology. So we're all sort of on the same page with that. Office-based data on process changes and challenges that you have lived, but you may or may not have seen data on it that others have collected. Office-based infection control considerations, some school transmission information and opening information, and how providers, how we may educate families and educate schools, and which is where sort of the intersection is between us, doctors and providers and schools and families as a group, and then recommendations moving forward. Okie doke. So just to start off with a graph that at least today's graph or yesterday's graph on the epi of disease in our country at the moment, and everyone is very familiar with this, I imagine. Here's our surge, and here's what's going on as of yesterday. So we seem to have flattened out a little bit. I won't go into any reasons why that may be. I think we all have some ideas about that, but this is where we are today in the United States as a whole, and this is where we are with LA County. And we are doing extraordinarily well in LA County, and we have for a couple months now, which is fantastic. I mean, the number of cases per day that we have, which is this blue, light blue curve, you can see my cursor moving, I hope, right? This is as low as it's ever been.
Sorry, yes, we can see it.
Thank you very much. This is about as low as it's ever been during the pandemic, as you could just see right back here when it all started. This other blue line is the deaths, and of course, The deaths have also diminished, and they, of course, peak 6, 8, 12 weeks after the surge, as it did here in the summer with the summer surge. All right. This is from the New York Times, which is really hotspots in the country, and we are not a hotspot, as you know, as I just said. Michigan, many of us have heard about, and this is just the dark red. As you get darker, it's more of a, quote, hotspot. And here it is, though, per capita. And Southern California kind of reemerges, okay? So it just depends how you measure these things. I think it's fair to say we're doing well, but I certainly will not suggest that we're out of the woods by any stretch of the imagination. So that's where we are as we speak. Vaccine coverage. I don't obsess on a lot of numbers. The data I just showed you, I don't check every day or anything like that. But one thing I do check every day is vaccine coverage. I happen to be a vaccine researcher, and it's always been a passion of mine. So it's always clear, I think, to many of us that it's really the only way out of this, along with our normal mitigation strategy. So these are the data from Los Angeles County. Can you? I think you can see this. But let me just ask a question. My pictures on the screen, they're not blocked. You don't see. You can see my full slide, right? You can see LA County vaccine coverage in the upper left, I imagine.
Yes, we do.
Yes.
Perfect. So over here is the fully vaccinated. Now that means 2 doses for Pfizer and Moderna and 1 dose for J&J a couple weeks after. And it's fortunately broken up by age, which is nice. And what I always look at is the proportion of the population over 18, the adults. And in LA County, it's 36% fully vaccinated. And in our seniors, it's about 61%. And if you look at the country, this is for 1 dose only. If you just add roughly 15% based on the US data, you get to the numbers for who have only had 1 dose or partially vaccinated. So for adults over 18, it's something on the order of 50, 55% nationally, and probably the same thing in LA County. And for our seniors, it's over 80%. It's astounding. So the media reports any number of things. They often report this number, which is the fully vaccinated in the entire population. But of course, children under 16, as you well know, haven't had the opportunity to be vaccinated. So I'm encouraged by these numbers, and they're continuing to go up slowly. Now, what about the epi in children a little bit? So these are data from a collaboration between the AAP and the Children's Hospital Association. And they put out every week or two these data. And I just want to point your eye over here. Over here is percent, and this is by state. And this is the overall percentage. This is the percent of cumulative cases in children. And nationally, to date, it's about 13.6. Just for giggles here, in California, it's very similar to that number. We're very close to what the national average is. Here are the states which have higher percentage in children. And it's just of some interest. Now, this is overall 13.6%. Now, what is of some interest is that as time has marched on, that relative proportion among children of all cases in the country has gone up. Why? Probably because of vaccination. We're taking cases away from adults, as it were. And in the most recent data, children account for about 1/5 of all cases nationally. This is a pretty graph of dark blue of children, and this light blue is adults. And you can just sort of get a sense of how it tracks. So yes, the proportion of children who are getting COVID as a measure of total disease is going up. The absolute numbers is another story. Now, nearly every state has seen this same relative increase in pediatric disease. Now, here are the variants. And I'm presenting all this data, by the way. This isn't a talk on really granular details on the epi of COVID, but I want to set up a frame so that when we talk about the offices and schools, we know sort of where we are. These are the variants over time. And I've labeled for you, these numbers are pretty meaningless to people that don't follow this every day, myself included, but I went and looked them up. And here in California, you can see here, we're dominated by California variants. They're called variants of interest versus variants of concern, and all that. Really, the only difference here is sort of the likelihood of transmissibility, the likelihood of morbidity, whether the vaccine will work. So in California, this is approximately 1/4 maybe of the disease is this UK variant, and the majority is our 2 separate California variants of interest and a smattering of other things. The South African variant everyone talks about and the Brazilian variant everyone talks about are not significant in this state to date. They have been identified, but they are not to the level that is concerning. In the United States, the California variants play a much lower, much lower proportion of all of them. The New York City variant creeps its head up here, and this is the UK variant. Okay, so this is just some sense of what's circulating. There are hundreds of variants. The media, of course, talks about the variants of concern, and for whatever reason they choose to discuss certain variants, but there are hundreds of them, and just keep that in mind. And this is not unusual. I think everyone in this room understands that viruses mutate, particularly RNA viruses. So let's get to clinical practice a little bit. There's some interesting data from the Commonwealth Fund. They use this FreeSIA database, which is the health technology company, and this represents a lot of practitioners. And these are data to try to get some sense of what's changed over time in office visits, pediatrics, age 0 to 2. And this is starting at March, first week of March last year, beginning of the pandemic, and it goes for a full year thereafter by week, which of course is this March. And the blue line is a weighted average of what we would have had there been no COVID. It's a weighted average from 2016 to 2019, and this is what actually happened in 2020. And I don't need to explain to you that there was a significant drop-off in visits, even in the youngest age group, which were a protected age group to some degree. And we have not got back to where we need to be. And that, of course, is the message here. In fact, these lines have been fairly parallel for a long time, for the last 6 months. Now, this is age 0 to 2. Age 3 to 5, very similar, of course, a precipitous drop, down to 80% drop. And then it's crept back up, and it's still parallel, but not back to where we were. And same thing in the age 6 to 17, about an 80% drop, parallel, and we're still parallel, but not back to where we were. So I know all of you know this. I know all of you know the dynamics of the patient flow in your own offices, but I thought there was value in presenting these data over the last year to us. Now, what about percent change from baseline from last March to the latest data last December? And pediatrics, unfortunately, has had the most precipitous drop. This is cumulative, 24%. It's more than twice as much as any other specialty that they studied here. And indeed, some specialties have recovered to higher levels than it used to be for a variety of reasons. These are all adult specialties. So pediatrics is sort of suffering here. And the last type of data in this regard is cumulative decline over the last year. And again, pediatrics, unfortunately, is the big loser here with pulmonology. That's just the way it is. But again, I thought there was value in these represent thousands and thousands of patients around the country. So there's some interesting information here that Sean O'Leary in Colorado and others did that really doesn't exist anywhere else. And they surveyed 579, nearly 600 pediatricians and FPs at the end of last year. And they wanted to get a sense of what was happening in offices. You all, of course, know what happened in your own office, but you may or may not know what sort of the trends are. Now, the data I have right in front of you is obvious. You know, they surveyed, did your practice require patients and families to wear a mask or a face covering? Well, of course, everybody did pretty much. Limiting the number of people who accompanied a patient to the clinic visit, just about everyone did. And you can see a direct comparison between the pediatric folks and the family practitioners. Changes to the physical space in some way to allow physical social distancing. Well, again, no big surprise that just about all of us did that. Changes to the check-in process to decrease or eliminate time spent in the clinic. Again, the great majority of us did that. And then we start to see some changes, scheduling sick and well visits during different times of the day as a measure of cohorting, as a measure of separation, as a measure of kind of a crude measure of not mixing air, as it were, as best we could. Peds, you know, about 70% of pediatric offices did that, and less than half of family practitioners did that. Giving vaccinations outdoors. Now you can think about your own practice and whether this is even feasible. About a third of pediatric practices did that. And what surprised me is 43% of family practitioner offices did that. I don't have an obvious reason why that is. Do they utilize drive-up visits for acute illnesses? Well, in pediatrics, about a third did. Same thing with FPs. scheduling sick and well visits at different clinic locations entirely. This building is for sick, this building is for well. Of course, we all don't have numerous buildings to choose from, but that happened in a substantial proportion of folks as well. So I thought it was kind of interesting just to sort of see what things people did and sort of secondary interest, how it compared to what family practitioners did. Now, again, I don't have easy access to chat, but if Tomas or anybody wants to tell me about a chat question, if it exists that's relevant, please feel free to interrupt me at any time. Okay, some more information here. Advising parents or patients to delay vaccines overtly, 10%. And now it didn't get into the details as to which vaccines or what age group. One might give preferential treatment to certain infant vaccines, for example, to say meningococcal vaccine in a 9-year-old or 10-year-old. I don't know what those data were. Family practitioners did this more than two and a half times as frequently as pediatric practices did. And scheduling sick and well visits, not just in a different location in the waiting room or in different buildings, but different days of the week, wasn't a particularly common practice. So again, just some interesting data to kind of frame for us and contextualize for individual practitioners what you're doing is or isn't, what others are doing. All right, what about vaccination? Did we stop vaccinating, excuse me. And this is just a distribution by age, 0 to 2, 4 to 6, 11 to 18. And in the youngest group, only 5% of pediatricians actually stopped vaccinating infants, basically. In FPs, it was up to 15%. And by the way, all these data, of course, are only among clinics that vaccinated in the first place. And you may say, I'm a pediatrician, of course I vaccinate, and of course you do. But only about roughly 23% of FP offices don't vaccinate children. So just keep that in mind as a baseline. Children 4 to 6, up to 20% of pediatricians did not vaccinate that age group. And the teens, up to 25%. And you all know, of course, the implications for this with regards to the specific vaccines. In this grade group, 4 to 6, we're talking about MMRV, particularly as a transmissible agent. And of course, in the older age groups, we're talking about meninge, we're talking about HPV, Tdap, this kind of stuff. So a not insignificant, or I should say, insignificant number of peds and FPs just chose not to vaccinate. And this was surveyed, by the way, at the end of last year. So, fairly recently, but in the beginning of the surge, I, of course, would add. Now, what about barriers to vaccination? Same survey. Why? What were the barriers? Fewer in-patient visits because patients just didn't come into the office. Obviously, that's a concern. And the nice thing about these data, it breaks down the pediatricians or the FP's belief as to whether it's a major barrier or moderate barrier. So I'll just focus on major or moderate. And about half, this was a big deal, that the patient just didn't want to come in. It was not a barrier at all in another 50%, roughly. So that may or may not be surprising, depending on your own personal experience. Fewer in-person visits for sports clearance, of course, was a big deal as well. And the moderate, and it's about a third, it was a moderate or major barrier. And overtly, fewer back to school in-person visits because some children are participating in virtual learning, i.e. they just couldn't come in during your business hours because they were too busy on the computer learning something. That was, in about a quarter of folks, a major or moderate barrier. So I think there's a lot of value in trying to understand what the barriers are if we're going to address them moving forward. And lastly, lack of PPE in the office. This is at the end of the year. There really weren't, there were ongoing issues, but there weren't substantial shortages. But it was still a major or moderate barrier in over 10% of pediatrician and family practitioner offices. So not trivial, I suppose. And utterly preventable, by the way. And then lack of adequate reimbursement when pairing a telehealth visit with in-person, that was a bit of an issue as well. And lastly, in this survey, you just didn't have staff. Well, 10%, not a big problem, it didn't seem to be. Parents' loss of health insurance coverage, again, about 10, 20%, not a humongous problem. And fewer in-person visits because providers are concerned about the risk of COVID, right? Not a big deal either. So I'm not sure these data are huge surprises, but I do believe there's some interest, there's some value in understanding where the country sits as compared to what we do individually. All right. Reduce clinic staff. Oh, sorry, I did that right. Pardon me. Did the parent or the patient have financial concerns? Not a big deal. Looser enforcement of school vaccination requirements. I was a little surprised at this one. You know, 6, 14%, 15%. I heard this, I was on a committee call the other day, and someone from CDC said that they're aware of schools sort of just looser enforcement of school vaccine requirements, mandated vaccine for entry. And I asked that person, you know, what was the amount, or, you know, what was the real burden of this problem? And she didn't know the answer, but here are some data. So maybe it's 10 or 15%. And I just was kind of shocked at that, just because of how persnickety schools are about this whole concept. And they're also, of course, regulated to make sure this happens. Parental loss of transportation, not a huge issue. All right, so practices, pediatric practices have borne a significant burden. You know that. I provided some data on visits, missed visits, why these visits were missed, overt barriers that pediatricians and FPs have identified that contributed to these problems, and also that we have not gotten back to where we were before. So how do we balance patient recapture, I call it, and infection prevention and control? Pediatricians are transitioning back to in-person care to some degree. Some of you are doing it quite a bit. Some of you are doing it less so. How interested are our families, frankly, in coming back? And I would be very interested in hearing about that from you. I looked all over the place for actual survey data on this that was recent, not from the surge or whatever. And I couldn't find any information. If anybody has any, I would love to see it. But I think it's fair to say, I mean, we all know for a fact that not every family wants to come back into the office yet, but I don't have a good sense of the proportion. And in order for us to understand how best to get people back, it may be, there is value in understanding that, but we just don't have that information just yet. So how do we message from our offices? And this goes to some survey data that I just revealed as to what people are concerned about or how they behave. Maybe not what they say, but how they act. They're not coming because of this reason or that reason. So I think advertising your process changes to lessen your risk, to mitigate the risk to patients and staff, of course, but to patients I'm talking about, might go a long way to helping parents get back into the office. We have information from schools that they're afraid to go back, and I'll talk about schools a little bit for a variety of reasons. Why would that be much different from going into an office when, again, it's a potentially crowded situation? The impact on routine vaccines, which I just shared with you a little bit, is not insignificant. I can tell you CDC is extraordinarily concerned about this, particularly as we move back into the fall, and how to make this catch up happen for school entry, not to mention chronic disease maintenance and everything else that pediatricians and FPs do to take care of children. And then also what your practice uniquely provides. You know, every practice has in their head and in their business plan what it is that they provide to their specific community that may be different from a practice 20 miles away. And I would suggest, and I do this with trepidation, I'm not here to literally lecture to practicing clinicians how to run their business. I'm just suggesting some things that you might do based on some data. You certainly should note that most of the healthcare workers in your office, I'm guessing, are vaccinated. That's reassuring to people. This issue of losing health insurance, I appreciate that getting VFC certification is not trivial, and you wouldn't necessarily do it for an individual patient. And this may be a little late, but anyway, folks that do overtly lose health insurance, of course, are eligible. We were talking before the meeting started about roughly half of our state children are Medi-Cal. So there are issues here, but it's something to think about. And the front office, and I know everyone appreciates the value of the front office, but actively utilizing the front office as for reminders or recall or a phone. You're already using them probably more than you might have in the past to set up telehealth. Just throw it out there as a reminder to recapture patients.
Dr. Zangwill, I just want to point out in the chat, Dr. Rajashekar mentioned that he's experienced 30 to 50% no-shows during this time. And also Dr. Knoll says that parents being prohibited from bringing additional children with them was a barrier in their office.
Well, thank you for sharing that. And I absolutely believe that. And I will say that as we move along in this, and many of you today might have seen a new CDC guidance on masks out of doors for people who are vaccinated. That is, you can sort of walk around without masks and gather if you're a group with vaccinated people. And that literally came out today. And that may not have direct relevance, it certainly does not have direct relevance to waiting rooms, for example. But it is the beginning, I believe, of the slope. And maybe some guidelines will change that allow us to allow more parents into the building, for example, if they are vaccinated and masked and maybe even distanced from other folks. So I believe completely that complaint and that reality in that office. So let's transition for a second to transmission and the office. I'm not going to go over all the details about transmission. All of you are very aware of this. It's transmitted by close respiratory droplets. There is, of course, a raging argument in some circles about whether or not it's overtly aerosolized in small particles. I'm not going to get into that here. I just quote here what CDC says, that it's certainly possible that there's been the occasional transmission through long distance aerosolization, and particularly in poor indoor ventilated spaces. It's pretty clear it doesn't transmit outside. So I think it's not fair to say that it's never aerosolized, but I think it is absolutely fair that the great majority of disease is through close respiratory droplet. So I just set the stage for all of us here. So the PPE issues. Now, look, you all know a lot about PPE. I'm not here to tell you about stuff you already know. I'd like to try to point out a few things that might have some practical significance, I hope. So when you're seeing patients, you have potentially a kid in there with has no COVID symptoms at all, of course. They're here for whatever they're here for, chronic management of congenital heart disease or something, or whatever it might be. And I don't know, I've not seen a survey anywhere about what pediatricians are doing for those kinds of patients. I can tell you what we do and what the general recommendation is, and that is a surgical mask and eye protection. Because as everyone in the room knows, there may be asymptomatic carriage of the virus itself. And depending on the study you read, that accounts for 35 to 40 or 50% of the overt transmission in the adults, maybe in children. So this, of course, is a preemptive measure. And then we certainly allow for disinfection of eye protection because face shields and goggles are expensive. So this is sort of the routine for the regular patient. Now, a person under investigation, a PUI, that term has kind of fallen out of favor. That it basically means, as you know, I imagine anybody with symptoms consistent with COVID, and that's where full PPE is recommended, which is a face covering, eye protection, gowns and gloves. And I will say that a surgical mask, as you probably know, is sufficient, unless you imagine an aerosol generating procedure, excuse me, an aerosol generating event or procedure, an AGP may happen, for which an N95 is recommended. You know, some people say, well, you should just wear an N95 all the time, and that's reasonable. They get a little clunky, they require fit testing, they're just annoying, but fair enough. So the key here, though, since everyone knows that, or should know that, or knew it, and maybe forgot, staff education opportunities. And, you know, we see this all the time. Look, it is, you know, it is tough to walk around the office all day long with a surgical mask and seeing patients and having eye protection and disinfecting and, oh, maybe an N95 because I think the kid's going to spit on me, whatever it is. It's tough. It's fatiguing. It's emotionally draining. We experience that in the clinic. We experience it in the inpatient setting, all over the place. So at least consider, if you possibly can, if an AGP might, an aerosol generating event might happen in your encounter with that patient. And if so, make sure you have your eye protection on, even though you're supposed to have it on anyway. Just know that you can reuse an N95 up to 5 times. That was sort of the dictum from NIOSH and EPA and everyone else back when N95s were in real shortage. They're not in real shortage right now. And the way you do that, by the way, is you just stick it, you use it and you stick it in a paper bag until you use it sort of later. That's how that works. I think the key, though, is flexibility. The particulars, the basics of PPE, I think we all know. The challenge is the implementation, the remembering, and the sort of the emotional wherewithal to think before we go into a patient room. That's what I just wanted to emphasize. Again, it's nothing you don't know if you were forced to answer it on a test, but it is tough to remember all that, I think, in the daily grind of seeing a lot of patients sometimes. So as an infection control director, I can't possibly have any discussion without mentioning hand hygiene. It just so happens to be relevant here because we talk about PPE, we talk about defining an aerosol generating procedure, we talk about warning ourselves when we're going to come in contact with such a procedure, but hand hygiene really does remain the cornerstone. Proper hand hygiene, I won't go over that. And I will share with you adherence among healthcare workers. I'm not just talking about inpatient doctors or nurses. I'm talking about clinic physicians and nurses is always suboptimal. It's never perfect. And that's just a statement of fact. It's not a judgment. It's a judgment if it were 50% compliance. And it's not usually that low. But again, this is another thing just to remind people. And I share this. We did this ourselves in our own hospital. We just took random folks who hadn't washed their hands or just working in the building and said, please stick your hand on this agar plate. And you'll notice it looks like in the shape of a hand, right? Another hand. And I don't know what that is. But the point is, of course, tons of germs. And this is not news to you, but I think a visual is very effective sometimes. And I will just share this. I don't think I need to say a whole lot here. We see rampant abuse of gloves in the outpatient ambulatory setting as a replacement for hand hygiene, and it just isn't. I think you all know why, and I think you all know why it happens. It's just convenient and easy sometimes, particularly for folks that are involved with procedures and other things that are going on. So just as a reminder, I'll just leave it at that. All right, dealing with aerosol generation is absolutely a thing in the outpatient setting and in any setting, of course. I would be liberal in your definition. Technically speaking, it is aerosol generation is when droplets are produced, of course, they're expelled from a potentially infective source to an unwilling participant. So exposure to mucus secretions. And there's a whole lot of procedures that all of you as physicians and whatnot will know are aerosol generating, intubation, all this stuff. You don't intubate, particularly in the outpatient setting, but you do some things that may generate aerosolization. You may suction patients. You may do a trach change. You may do nebulization. There are any number of things that you might do. Even just any kid, of course, can just cough in your face, obviously. That's why we want people, even if they're asymptomatic, to wear a face shield. And let's keep in mind, I just had this discussion the other day with someone, you know, the mask is, of course, over the nose and mouth, and it's meant to prevent direct inhalation of these droplets. And the face shield, of course, is meant to block overt deposition in the eyes. Some people have been confused by the notion, or at least used face shields only. You know, makes sense. Look, stuff's coming at me, the face shield blocks it. But of course, that does nothing for the inhalation aspect. So just as a reminder. Of course, we need to limit performance of our aerosol generating procedures. And there are various ways to do that. Sometimes, and it completely depends, of course, on your infrastructure, your facility, and your available space. By the way, if you have available outside space, I told you a third of pediatricians, I think it was, vaccinated outside. Maybe they had a tent, maybe they didn't. Why can't they do, and maybe they did do, aerosol generating procedures, nebulizations, and things out there. A dedicated room, of course, if you possibly can, and to certainly minimize staffing in the room when that trach needs to be changed or when whatever you're doing that might generate aerosols. It was popular and appropriate to try to replace nebulization as much as possible with MDI, with spacers. And then, of course, we all did it and there was a shortage. I don't actually know if, maybe someone can tell me if right now there's still a shortage of spacers. I don't know. But obviously it helps to avoid the problem of overt nebulization. I'll also share with you that there's a lot of debate as to whether nebulizers are really even that aerosolizing. You know, World Health, I think, says no. I think CDC is equivocal. And in my own personal view, I don't think it's of high risk, quite frankly. But I'll just share that with you. All right, ventilation. Everyone knows ventilation matters. I share with you a table that basically, this is air changes per hour, okay? And this is how long you need to ventilate that room or keep it closed or keep it unoccupied when you can get 99% removal of what you're interested in, viruses, basically. And of course, every medical clinic is different. Everybody has different air changes per hour, but roughly speaking, engineers have looked at this. The medical clinics are somewhere in the order of 8 to 12, which is right here, which means 20 to 30 minutes, roughly, of ventilation is probably sufficient to get rid of 99% of what you're trying to get rid of. Okay, you've read an hour, probably for those of you that are in hospital settings or take care of inpatients or read other stuff. And that's what we do in the inpatient setting. It's just easy. Although I will say we recently changed it because we got granular and we figured out all our rooms, not the inpatient rooms, all the settings, the CT scanner, this, that, and they were different. And we changed it because this is a critical barrier to anything. If a room has to be empty for an hour, that's a big deal compared to 20 minutes or whatever it might be. By the way, I can share these data or these slides after the talk. It's a lot of information. I appreciate that. All right, surfaces. Let's talk for a second about surfaces. Every office has many surfaces. Every house has many surfaces. Every family thinks about surfaces, or they used to. I don't know if they still do. Just be aware, there were tons of opportunities if you were an academic researcher to PCR every surface and say that you could find COVID all over the place. That was meaningless. PCR detects, as you know, genetic material, in this case, RNA for COVID, but without understanding whether what you're detecting is live and transmissible, it's meaningless. It could be dead virus, it doesn't mean anything. So there are some studies on live transmissible virus, and the general, if you sum this up, there aren't a lot of data. If you look at lab data where a researcher or something will purposely inoculate a table with a known concentration of virus and then adjusts the humidity in the room and adjusts this and that to maximize growth, they will detect transmissible virus. There is a 99% reduction in infectious virus within 3 days on non-porous surfaces, which is like, hard tables and steel and glass and plastic. And if it's porous, it's very quick. But it's very important to know that these are sort of not normal real life situations. Again, large inoculation, optimize the environment. So there have been a couple studies from the community. They just went out and sampled traffic light, traffic buttons and all kinds of stuff in the community. And maybe in roughly 5 to 10%, they can find some PCR positivity, but again, no viral transmissibility. So again, it's practically useless. I mentioned here the PCR CT value. What this means is the cycle time. PCR, polymerase chain reaction, is a process where you probably know that someone won a Nobel Prize for this, by the way. They amplify DNA in a machine millions of times in a variety of heat cycles. So we take a tiny bit of DNA, RNA or DNA, whatever it is, and replicate through the first cycle, and then you see if you can detect and keep going. And each time you go, it's considered a cycle. So if it takes you many cycles to detect virus, the presumption is that you started with a very small amount of virus, and it took a lot of cycles to generate enough for detection. So if in these studies where they were PCR positive on traffic, outside, door handles, that kind of stuff, the CT values were typically very high, which means very low concentrations of virus, which probably means not particularly infective. And when you look at modeling data, it's been estimated that somewhere just in the community, 1 in 10,000 touches in, say, a medical clinic or something may or may not result in transmission, or at least acquisition on the finger. It's it's model based. There's no real data to support that overtly, but I just share that with you because it's out there. So surfaces are not going to be a big problem with transmission. Now, while we're talking about surfaces, disinfection versus cleaning. Again, much of this, I think, but it's worth reminding ourselves that soap and water is fine as a cleansing. It is a cleansing agent. It's a surfactant. It will get rid of pathogens, and it's just fine for waiting rooms and whatever you need to clean. We do recommend high-touch surfaces be disinfected, which of course is killing germs. Particularly if there's been a case in your office, a known case, a PUI that subsequently was found to be positive in the last day or so, and to ventilate if the known case was indoors. And please don't do deep cleaning. God, you see this on TV. I don't watch much TV, but we used to see this guy spraying stuff over the place in hazmat suits. Zero value. I've already talked to you about surfaces a little bit. Let me walk you through even more. I seem to have lost my fun slide about surfaces. Oh well. Anyway, the thing to keep in mind when you're wondering about surfaces, The virus has to make it out of the human. It has to land somewhere. It has to survive the environment and the humidity and the UV light, by the way, which kills things. And then it sits on there for a period of time. It could be minutes to hours before anyone, or days or weeks before anyone touches that surface. Then that person has to get enough on their fingers to be infectious to the human, and no one knows how many virions it takes. Someone's estimated 15 or 20, it's, who knows. And then they have to put it where it needs to go, and then they need to become infected. That's a lot of steps when already the virus is rapidly degrading on surfaces, in addition to everything I just said. So I'm not going to go through all these in any detail. I wanted to list the infection prevention processes in the office that you may or may not do to help mitigate. Telehealth has been brought up. You know what you know a lot about telehealth, and that has obvious implications for infection prevention. A triage process for diversion of symptomatics. Many of you undoubtedly have that as well. Waiting room or car separation, or using a car as a waiting room. Some of you might do that. I'd be interested to know how many. Care outdoors, we talked about certain times. We mentioned face covering, of course, for all patients. Ready access to hand sanitizer. And just to let you know, if you don't know already, it's got to be at least 60-65% ethyl alcohol to be considered effective. And of course, limiting the bodies in the room. We just had the discussion about how many people can be allowed with a patient. The fewer the better, but we'll see. Staff, of course, has to be masked at all times, and I would recommend surgical masks, not cloth masks. I think many of you are aware of the difference. Surgical masks are just better. Not only do they filter, they have an electrostatic mechanism which traps bacteria, which cloth masks never do. Staff symptom screening, many of you do this, some don't, at least that I'm aware of. There are many ways to do this. Of course, staff vaccination, strict break room management. I can't emphasize this enough. It's well known in the hospital, the inpatient hospital setting. This is where outbreaks start. People relax a little bit, all that emotionality I talked about in the beginning, and remembering to be protective of oneself goes away miraculously. Finally, they can sit down and talk to their buddy. They can eat lunch maybe or something. Limiting the number of people in that room, and being very cognizant of whether someone wants to eat in there or not with someone else, and how distanced they are is critical to preventing outbreaks in the outpatient setting. And of course, symptomatic healthcare worker management, I don't need to tell you about. Now, the facility itself, HVAC optimization and HEPA filtration, just know that, people talk about various levels of filtration, the engineers about various levels of filtration, the MERV scale, MERV 13 being sort of what's recommended. You may or may not know what your particular engineering is in your building. HEPA filters can supplement that, of course. And there are remarkably quiet HEPA filters, if you're wondering. We talked about AGPs. We talked about the waiting room. We'll talk more about the waiting room. Signage, stickers, and is everything you should know about. Now, the waiting room specifically is a challenge, as you know. Trying to keep as few people in there as possible is difficult. Digital remote sort of form filling, in-car waiting are obvious ways to make that happen. No soft or plush toys because they're essentially impossible to clean. Disposable activity sheets are fantastic, like restaurants. We talked about splitting up sick and well visits, either by location or by location in the room, or different buildings, or different days, or different times of day. Of course, having wipes and sanitizer available, signage, focusing your disinfection really on high-touch areas, and an overt rule that patients must wash their hands before they go from the waiting room to your exam room. That makes sense. That can be, yeah.
I'm sorry, there's a question in the chat. What if staff is all vaccinated? Can they eat together in the break room if all of them are vaccinated?
Right. The CDC would recommend that you could do that, frankly. They're putting a lot of stock, and I think it's reasonable, in the ability of vaccination to protect us. So I think the answer is yes. Now, people still recommend distancing when one is eating. But I think that is yes. But you got to be careful. I mean, we always have to be careful. We got to be cognizant of the room and the size and how many people are in there. There are no particular guidelines on how many or the room size or any of that sort of stuff. But yeah. Okay. Education and re-education, as I mentioned already, is key. So I won't belabor that. So what about the intersection of schools in your office? You may consult with schools. You may educate families about in-school risk. Back in the day, all schools were visited by the Department of Public Health. And they're still doing that, sometimes before opening and sometimes after. Patients may ask you or require a pre-entrance screening test to go to school, pre-sports participation, or maybe they're sick and someone needs to diagnose them or test them because they've been quarantined for a while or they're de-isolated for a while. You may have a role, you may have already encountered this. So where are schools open? California is just, we're last in the country. This is from Burbio. It's a great site. They track this all the time. The in-person index, the lighter you are, the fewer folks you have in-person, children, in-person in school. And we just are not where we need to be. In fact, as of yesterday, only less than half of California children were in school for any degree, even a day or two hybrid. It's just, it's a disappointment. I'm not going to spend a lot of time on virtual learning harms because I think this crowd knows most of them. We are aware of the disparities in just getting online, tons of learning loss, very little socialization, unless you count 2D as some sort of socialization. And pediatricians have reported problems with mental health and food and housing insecurity and less utilization of physical and occupational therapy. I will tell you, hard data on suicide and the more severe aspects of mental health do not exist. There are some bad studies on this, but I think it is clear that mental health is changed, but to precisely quantitate that, I think is tough. And never mind the excessive screen exposure when out of school. Most schools are not open full time, even when they are open. So these are the key data that I'm going to share with you as to why schools should be open. I have a whole other discussion that goes at length about why schools should be open, but this is the crux of it. Pick your country, pick your study, pick your site. This is the population, number of kids and or staff in the school. This is in the thousands or the millions. And this is the intra-school acquired cases. It's less than 1 in every instance, except a high school in Italy. There's a couple other studies, but the bottom line is intra-school transmission of COVID by students to teachers or teachers to students is extraordinarily uncommon. When it does happen, and many of us have seen descriptions, outbreaks, whatever, invariably, it is due to mitigation problems. Kids weren't masked. And I don't mean the occasional kid, which might happen in any school, but widespread, don't bother masking, or the distancing wasn't appropriate, or they were eating lunches as a gang, whatever it was. So this is really the key data. These are the key data that support the notion that schools should be open. I'll just share with you that around the country, and certainly in California, unions are very involved. And the problem is sometimes they often cite uncontrolled, confounded, or non-mitigated school data to suggest that it's a big risk, and it just isn't. So in LA County, I wish I had more recent data. I'll share this slide with you. There's more open schools now. I got these data in mid-December, and I got some more data in mid-February, where less than 5% of schools had more than 3 cases of potentially related to intra-school transmission. I don't have more recent data, but frankly, the cases are down since then, so it's probably not a lot. In fact, it's probably less than 5% as more schools came online and there was less transmission, but I can't say that for sure. It's a low number. And most schools, even in the surge, had no cases, and only 26% had a case. So that's LA County. I think I'll skip this in the interest of time. The question always comes up, school attendance and the community burden, never mind intra-school transmission, what happens to the rest of us? And if you look at these modeling studies, there's a couple of them, there may be a small reduction or a small increase in the community burden of COVID when schools are open and if you're in a surge. But there's no effect if there's low community disease burden, which of course is where we are here in LA. And look, we know this. Most California kids have been out of school for a year. Short-term damage is clear. School-based disease rates reflect the community. Intra-school policies, I shouldn't say policies, attendance does not drive rates, transmission's low, and outbreaks happen because of poor mitigation. I said that. So these are the big messages, I think, as pediatricians, we can send to parents and schools and legislators.
Dr. Zangwill,
yeah.
Dr. Roth asks the question, what is the protocol if a student or a staff member in the school tests positive?
Good question. So, of course, LA County, just FYI, as you might imagine, LA County Department of Public Health has very detailed guidelines on this. And if there's a single case, hopefully your school district has a school nurse or school doctor. And I will say they're in very short supply in, let's say, LAUSD, for example. They have relatively few. It's just the way it is. And one nurse may cover many schools. So let me just be clear about that. But of course, the protocol can vary, but the concepts are, of course, you make sure that kid doesn't come back to school. You find somebody somehow to do some contact tracing. And what that means is identification of susceptibles, identification of contacts in the school. And how that is defined has changed. It depends a bit on how the school runs. It used to be the whole class. Public health even used to say this. Now they don't. The public health approach now is a measured approach to, you can get them involved even with a single case. And I think that's an important message. Call them. They will talk to you. And they will work with you to figure out who was within 6 feet for more than 15 minutes in a 24-hour period. And unfortunately, it doesn't matter if they were masked or not. That's considered an exposure. And that person will be sent into quarantine. It may or may not be a whole class, sports team, choir, whatever it is. But the protocol is identify the person, get them out of the building, initiate contact tracing, talk to public health, define your exposure group, and then follow them thereafter. And the folks that are quarantined, although CDC recommends testing, many of us don't unless they develop symptoms. But they do need to be quarantined for at least 10 days if they're, which is beyond the incubation period. So what can we do about schools? And I only have a couple more slides, I believe. Advocate for full fall school reopening based on the data I showed you. And trust me, there are more data out there I can share with people offline. In my estimation, full fall school reopening is mandatory for all the impacts, all the negative impacts to mitigate that, all the mental health issues, all the school learning loss issues, the impacts on individual families. I think everyone in the room understands that, or the implications, I should say. Inquire of your families to obtain real world virtual learning experiences. I'm shocked at some of the stuff I hear. Again, I'm sure many of you have this experience. Identify the medical impacts. I shared with you what some data show, but undoubtedly, I'm positive everyone in this room has heard or experienced or witnessed or helped treat or mitigate or assist families with some medical impact that never has been reported. And take a stand if you can. You know, not all of us are activists, but trust me when I tell you that the legislators, the decision makers at the state level, the Board of Supervisors, and everyone else wants opinions from pediatricians. And I've spoken to some of these people. They want to hear from us. We're not absent. We have done a little bit, but do something if you can. Op-eds, engage with the media, contact anybody and everybody. These things actually matter. They really do. And so how would I summarize this talk, which is a challenge? So I think it's clear that pediatricians and patients, both of us, both groups, took a big hit during this pandemic, and it's still going on. People are still afraid, and we're still not where we need to be. But office reopening, I think, needs to move ahead, and I think many of us are doing that. Families need, however, ongoing education, not just for those that may not be aware, but for those that have been actively fed, if you will, misinformation about the disease and about infection prevention mitigations. And I dare say staff requires that ongoing education as well. We need to address routine vaccine coverage. This Ishmander Karo is going to be doing our next talk in this series that was announced. I'm not going to talk at any length about this particularly, but this is a huge priority for the AAP and the CDC. And just wait till the COVID vaccine gets licensed, which I hope it'll be in the next few weeks for kids over 12 for the Pfizer vaccine. What are you going to do in the fall? Flu with COVID vaccine? There are no data yet. There's no data on co-administration of any vaccine with COVID vaccine yet. But it's a thing, and it's a high priority to be studied and recommended when the data emerge. And doctors involved with IPC-related school-based issues. Reassurance, notes for schools, testing, advocating for adherence to vaccine laws. Anything you can do will be, I assure you, appreciated by your local school or whichever district you may be working with. And I know some of you are working overtly with districts, as do I. So this is the goal. A waiting room with actual children in it that no one's giving a second thought to putting anything in their mouth. And of course, this happens to be my elementary school, and my kid is right in here somewhere. But a full school with happy children and a full waiting room is the ultimate goal here. So I'll just leave this slide up here for a moment. I'm not going to read it, but these are some references for you, some web-based references for you and for your families with regards to the science, where you can get signage if you don't already have it. Provider us help. A lot of interesting stuff here. There's a discussion board through the AAP. And for families, healthychildren.org is an AAP thing as well. Many of us have contributed to this. It's lay language for parents. It's not for doctors or providers about any number of topics, including COVID. And you need to get your patient tested quickly, and you're not doing it in your office, or maybe you have a send-out lab. This is where families can get it through the county. And I've been on this site myself in the last day or two just to check it out, and it works well. So I think I'll stop there. Again, thank you very much for the opportunity to speak with you all. I appreciate it. Any questions? I'm happy to take. Oh, now I can see chat. So let me go through the chat. Is that okay, Tomas?
Yes,
see.
of course.
Okay. Let's see. Is K95 as protective as N95? Yeah, so K95s basically are, but they were from China. We had a bit of a problem with them early on because they didn't seem to fit as well. We had more fit testing problems, but you can use KN95s as long as you can get them fit tested and you're confident in them. Oh, Tempe Chen seems to have answered that. Can you comment on the notion of hygiene theater and what kind of disinfecting may need to be done for PUIs? For example, do we need to air out a room? So hygiene theater is as I understand it, and this is of course a lay term, and I've only heard it a couple times. I believe it's this notion of over cleaning and being particularly demonstrative about it. And it sort of, I believe, results from fear, of course, and perhaps a little bit of misinformation or lack of direct information. And Tempe, if you have more to share on that, please do. Do we need to air out a room after potential PUI is seen? Yeah, I think the answer is no, actually. Most PUIs, I dare say these days, probably do not have COVID. And of course, a PUI is only a person under investigation. We do our full PPE, we do what we need to do, we get them out of the room, out of the building as soon as possible, we do the test if we need to. It absolutely isn't always possible. I appreciate that. Now, the conservative answer to this would be to try to air out for 20 minutes or so, which might be adequate, or 25 minutes in a medical office. But I get it. Look, you're seeing patients every 20 minutes potentially, and that could be absolutely impossible. So this is the flexibility. This is the marriage of implementation to science, and that's the best we can do. I wish I had a more definitive answer for you.
Yeah, that was, Ken, that was what I was referring to. I mean, I think a lot of people are always, trying to disinfect after every use. And it gets to be this thing where you're doing all these practices and it's not necessarily based in science. So thank you for mentioning that, because I think it's important for people to know really hand hygiene is what we need to do and what we need to focus on. And, there are some earlier studies where people were saying, try to air out a room for like 2 hours. Well, you can't do that. So I'm glad you mentioned the 20 to 30 minutes. And, there was a doctor that was doing like a YouTube video on disinfecting the mail and disinfecting your groceries. And it was kind of driving a lot of us in the ID world a bit nuts.
Well, thank you for asking the question, Tempe, and you're right. And hand hygiene is the cornerstone, as you reiterated. So I have nothing to add. You're absolutely right. Thank you. I found it was hard to switch between full PPE and regular protection, especially in patients that we didn't know had symptoms before being roomed, but became PUI after. Yeah, that's a tough one. You go in there sort of, if I understand your question, where we didn't know how, right, exactly. All I can offer you is consolation. You go into a room hoping that bad things don't happen, hoping an AGP doesn't happen, hoping the kid doesn't spit on you or do something horrible, and next thing you know it happens, or later it's determined that they had COVID or some such thing. All I can tell you is this: among us, I'm imagining everyone on this call, or the great majority of us, are vaccinated. So keep in mind that we're vaccinated. Keep in mind that you always have, at least I hope, a surgical mask on in the office. So if the PUI didn't generate an aerosol, then surgical masks are adequate, okay? And face shields are adequate. And presumably you had at least a face shield and surgical mask, because you're talking about going from full PPE to not. So if you have a surgical mask on and a face shield and you're vaccinated, even if that person was a PUI and there's no AGP, you're gonna be fine. And remember, even in hospital settings, it's recommended that EVS, or folks that clean all the rooms, can safely go into rooms before the ventilation time is done, because they're got the PPE on plus or minus vaccination. We even did that before a vaccine. Okay. Even if staff is all vaccinated, we can't let them eat. Well, I think I answered that. What will schools do if a child tests positive, or staff? I think I just answered that as well. Weight gain, depression, just to name a couple. I assume that's some morbidities that you've seen that aren't necessarily articulated or even reported on very much. Obesity has been discussed. I believe clinicians, I believe you when you say you've seen this. I've not seen any actual hard data with lots of numbers, but I believe it. In the Inland Empire, at least 2 school districts are refusing to accept negative rapid COVID antigen tests for school clearance. I guess school clearance must mean, being able to come to school, I'll assume. Maybe Dr. Null could clarify that, which is what we have in our office and can easily offer patients in conjunction with the PE. Of course, what's your opinion on this policy? I don't like that policy. I actually am not a big fan of testing of any sort for school clearance. As we say, a test today is a test today. And of course, what that means is tomorrow they could be positive. Given what we know about the epidemiology, given what we know about transmission dynamics, given what we know about the weaknesses even of nasopharyngeal PCR, which is the gold standard, the likelihood of turning up someone positive in an average school screening system is extraordinarily low. It's so-called number needed to test, right? And the efficiency is low, and it's expensive. So we don't recommend, very few people, there's no official recommendation for school pre-entrance screening for schools, although I'm aware that many do it. And the antigen test is slightly less sensitive than any test that detects genomic material. It's not radically less sensitive, but it's at least 15-ish% less sensitive. Another reason not to rely on antigen testing. Colleges do this a lot because it's easy, fast, as you articulate. And for them, it's kind of cheap. And they have different sort of motivations, but that's a long answer to that. I apologize. Suggestions regarding medically fragile children requiring oral suctioning in classroom, frequently if separate room not available. Portable HEPA filter adjacent, plexiglass barrier, N95 for aid. Yes, yes, yes. This is a very challenging area for schools. Schools, I used to make the point to schools early on that I appreciate that you're not professional infection prevention people. You're educators. And now suddenly they have to be IPC people. It's a big challenge. And now you throw in a medically fragile child. So anyway, I won't pontificate. I think your suggestions are the way to go. Outside is good. Separate room is good. HEPA filter adjacent is fine. I can't guarantee its utility because HEPA filters are designed for air spaces, and it's not like they suck the air out of everything around it sort of efficiently necessarily. But I'm not sure I have any extra suggestions for what you just articulate there. Aside from not scheduling these things, I had a discussion with someone who's on the call here about buses and kids with trachs and other things on a bus. And if they have an emergency on the bus, that's one thing. But certainly discussions with families about having discussions with families about not scheduling or not having a schedule such that a trach or anything needs to happen on a bus, of course, makes sense. Excuse me, I need to tell my young daughter I'm on a call. I'm sorry, I can't help you right now. No, thank you. Okay. That's a challenging
we only have time for these 2 last questions, if you can.
Okay, sure. Return to school testing after cough or sneezing and nausea. I think that is a very individualized decision. I would never recommend that we test every kid with a snot nose. In fact, we're right now seeing a little bit more rhinovirus and enterovirus in the community. There's even a few cases of RSV. I have to defer to your judgment as to whether or not you really believe this child has a decent chance of having COVID. What's the sort of the a priori likelihood of having COVID? And I appreciate that that's tough because a lot of kids are asymptomatic. So as I talk, I appreciate the weakness in my argument, but it has to be left up to you and your clinical judgment as to whether to test or not, quite frankly. And the last question is, I had a parent today asking for serum allergy testing because the school wouldn't accept her back in class without it. Okay. Yeah, all kinds of things happened in schools, and you all know that. So I guess I have to end there. Let me just say that to Tomas, I'm willing to share my slides, or most of them anyway, to folks if they want them. I really appreciate the opportunity. I really appreciate hearing from you all about what your concerns and your thoughts are. And that's all I have to say. Anything else I can help with?
Dr. Zangwill, you've been fantastic. Thank you so much for your amazing presentation. And thank you for making your slides available, because it will be useful not only for the entire content, but also for the last page where you have the resources. We do have a page where we are putting all the information from this series. So we really appreciate that. Thank you everyone again. And thank you, Dr. Zangwill, for this amazing presentation. We're really, we're delighted to have you tonight.
My pleasure. Thank you to everybody.